Center for American Indian and Alaska Native Health Education and Research at the Oregon Health and Sciences University. He is a member of the Cherokee Nation at Oklahoma. And again, as all of the presenters have, an extensive expertise, qualifications, experience. So we just take that for kind of the baseline for our conversations. So with that, please help me welcome Roger Walker. Roger Dale Walker. I've never actually called him Roger. I've always called him Dale.
Hi, can you hear me with this, everybody? Well, my name is Dale Walker. I'm Cherokee. I'm Bird Clan from Claremore, Oklahoma. I've been working, I'm a psychiatrist. I've been working with addictions and mental health issues and doing consultation and tribal assistance for 42 years. It's an honor to be here, and I wanted to maybe share a little bit with you the opportunity that all of you have. You've been able to compete to gather resources and for treatment in what I think is the most difficult treatment area in all of medicine. And you all are tasked with making a difference. And that's an honor that you have for your tribe. And I guess I want to dedicate this talk to your efforts and your energies to make a difference and to reduce the problems that are there in your community. The other thing I guess I want to mention is that it is the most difficult issue for a lot of reasons. And we heard some of those reasons this morning with the long-term problem. Addictions and comorbidity are chronic illnesses. And all of medicine has never done a good job with chronic illness. Many of our communities haven't done a good job with chronic illness because we want them to get better, and for some reason or other, they don't. Some people see that and they get mad at the patients. Then they say, treatment's no good, so they get mad at the treatment people. Then they say, we might as well, why are we spending our money? So let's stop it. So you folks have a lot to say in that discussion with all of the work that you're doing, whether it's with MAT programs, whether it's programs with youth, whether it's programs with elderly people. You have an opportunity to develop an avenue to help those people get better. And you need to work with the community. You need to work with the tribal council. How many people here have gone to a tribal council meeting and presented? Okay, those people, I hope you keep doing that and develop your agenda. You've got to help reduce the stigma. You've got to help a pathway to work in that system. That's as hard as the treatment of the patient. And so, you know, you have that difficulty of working. So we're going to talk about in comorbidity, how might you do that in an effective way? And I think that's going to be the primary discussion that we have about how do we work together? Is there hope of developing an integrative care model where we can work across systems, across our community, with tradition, arm in arm? We have to look at the whole process in that way. Now, if you go to your own emergency room and talk to the nurses and doctors and the clinicians who work in those emergency rooms, and you ask them, who are the toughest folks that we see? It's going to be substance use disorder, and the second is going to be all those mental health problems. Because we can't refer them out. We don't know how to treat. Our system isn't big enough to care for them. And the most heartbreaking of all, we're busy taking care of real patients. And so you've got to deal with those problems, and you've got to justify your existence to keep that system alive. Somebody talked about sustainability in developing your systems this morning, and that's going to be a critical step. And so here you are dealing with the hardest to treat patients with chronic problems, so it's long-term, if not lifetime. And people are wondering, why don't you get these people better? Why don't you make this work? And so those are the discussions that we're going to have. And remind me, I want to talk about drug cartels before we finish up too. Well, let me just go on here and talk about some goals. Now, I know that you can't see the slides maybe from the first table back. These slides will be useful when you get them, and I've tried to set it up on any term that you hear or any term that you see. All you have to do is Google it, and it will give you a definition about what it is. We've got an interesting range of people, from physicians and psychologists and pharmacists and counselors and managers, nurses, all in this room. And you all have different training to bring to this formula. I'm going to do my best to level with this, but I want you to know all you have to do is to Google, take a look, and it'll help you explain that process. And also, at the end of this talk and on my slides, my phone number is right there. It's on my cell phone, and I invite you. I'm a consultant for all of you. And if you want to talk about these issues, you're welcome to. And I'm sure that the other speakers feel the same way, that we're here to make a difference, okay? Well, we're going to do an overview of comorbidity issues, and that's in general. We have to take a look at the problem of one drug and another drug together from what's going on. But then we want to look at, okay, now we know that. What about American Indian, Alaska Native comorbidity? Is there differences there? And what do we know about it? And I want to talk about comorbidity best wise practices. You've heard people talk about best practice, evidence-based practice. And if you really look at how to do this, it's best wise practice that makes the most sense. Integrated treatment is our mantra. We really want to work across systems. Now, all of you people in the room, how many people had another job before you got this grant? Raise your hand. Yeah, you all had other jobs. How many people still have that job and now they got the grant? So your workload is now doubled, right? And that's an issue. And you're kind of spinning your wheels in all directions, and it's important to kind of think about that and try to get a framework for the type of work that you're doing in an integrated care. I can tell you, if you have 2 full-time people working and you walk over to them and say, oh, good news, we're going to work together, that means more work for both. Okay? So integrated care is not an easy thing to talk about. We'll talk about how to maybe do some of that as this conference goes on. Finally, we're going to look at possible community solutions to these issues. Again, you guys are the workers, but the decision makers need to know what you're doing and need to support that process. Well, the first thing we're going to talk about is overview of comorbidity. And I wanted to share this slide. Again, it's going to be in your handout. It's a breakdown in 2016 of mortality across the different ethnic groups, a national average in white, Indian, black, and Hispanic. And you'll see that American Indian and white in the drug mortality is about the same, 26 per 100,000 deaths. But let's not forget our old friend alcohol. And that is 46 per 100,000. Now, do those numbers mean anything to you? You know, maybe it may be more useful to give you this. If you look at American Indian deaths for drugs it's 1,062 per year. For alcohol, it's 1,856 per year. Those are low estimates. Those are conservative guesses. Nearly 3,000 people die a year from alcohol and drug mortality. Let's go over and look at suicide. Now, if you can't see, you all know that suicide amongst our people is higher in the young years compared to other populations. We die early in suicide. We also know that a lot of suicide deaths are related to drug abuse and alcohol use. And so some of those underreporting for drug deaths are because they're listed as suicides. I can guarantee you that suicide reporting deaths across all of your communities is underreported. We don't like to talk about all the things that happen in ugly ways in our communities. It's very, very difficult to get data to study suicide problems in Indian country, and we don't like to talk about drug abuse problems either. There's an underreporting. So I've just shared with you that the conservative estimate is 4,500 Indians a year die from these three problems. Is that not a national emergency? Is that not a problem that we need to raise a lot more money than what you guys are getting for the TOR projects? We need a lot more work done in this area. You heard a little bit about we've had increases in prescription drug abuse noticed about the year 1999. We also heard that there was another wave of the heroin abuse that started in 2010. And then there's this synthetic opioid that started in 2013. Now, why do you all think those happened? Greed? Greed by pharmaceutical. What other kind of greed might there be? Prescription issues? Who said the magic word? Cartel. I'm going to talk about that. Drug cartels are fascinating. They're like Target, Lowe's, Walmart, only they're bigger. They're bigger than those companies. They have more money, they have more resources, and they have more drugs. Isn't it funny that we've, except for one comment about methamphetamine, remember a few years ago when methamphetamine was an issue? When did that happen? That was kind of right in here, right before the heroin stuff started. Methamphetamine was a problem across the country. We threw a few dollars at it in Indian Health Service and across Indian country, and suddenly it's gone as an issue. We rarely talk about it. Those resources, dollars are gone, and now we're talking about another problem. How did that happen? The heroin producers realized that the methamphetamine was undercutting their market. They have made a stronger product. They've marketed it towards children. They've been able to make it more available than it ever was before. And so the use has exponentially grown. When heroin did that, everybody said, if we could only get some of the really hot synthetics, if we could only produce those and get them into the country so that we can get fentanyl out there and make it available to more people. And so these companies are manipulating the drug abuse problem. And we need to understand that in our communities. The drug people in this country who make legitimate drugs are also more than willing to make their drugs available. And those are issues that somehow in your treatment programs, you need to have that kind of information. Now, comorbidity. You all know what comorbidity means. It's two or more disorders or illnesses occurring in the same individual. And they might happen at the same time, and they might happen in line, one after the other. So a person could be, quote, comorbid. You all, how many people here treat alcohol drug now? How many people are doing that? Everybody? How many people have seen mental health problems in their patients? You know, we're going to talk a little bit about how often that is and maybe how we might look at some treatment processes for it. The other thing that's scary about comorbidity is that when you have two problems, it can make each of them worse. And if you know, whenever you work with a depressed patient who is an alcoholic, who is an opioid abuser, you have to kind of work with that and partner to get the work done. That's what integrated care maybe can be useful for you. Well, a long time ago, we started looking at lifetime history for comorbidity and alcohol, drug, and mental health problems. And one of the first pieces of work in that came out in 1990. And I'll only mention this briefly, but back then we thought that in the United States, 22.5% of the people have a mental health problem. Alcohol disorder, 13.5% of the total population. Drug disorder was 6.1%. Now, the interesting thing about that, they then said, you know, maybe we ought to look at comorbidity. And we found that mental health was comorbid with alcohol and drug 29% of the time. Alcohol disorder was comorbid 45% of the time. Now, hold on to your hat. Drug disorder was comorbid with both mental and alcohol 72% of the time. You guys are taking on the toughest people around. They're comorbid 72% of the time. Now, more recently, that data has changed a little bit to a much better way of analyzing. And we find out that, and they've grouped it together in a simpler way, there are 43 million people in the United States have mental illness issues. 19% of those have substance use disorder. If you're treating the substance use disorder, and that's 19 million people, 41% have mental illness. And so again, you need to work and partner with behavioral health. I've always argued that, you know, are there addictions counselors in this room? How about mental health counselors? I've always argued that you two need to get married. We need to have the same training and the same work between your two programs. In my state of Oregon, an alcohol counselor can't diagnose suicide ideation. In my state, a mental health counselor can't diagnose an addictions disorder. They're two separate things. And when I say you can't diagnose, that means and bill for it. Okay? And bill for it. So there's these limitations. I think you need to argue with your two associations to combine so that we have both integrated in your training programs. All right. Now, maybe this one I'm going to just keep real simple, but if you have any drug use problem, it will increase mental illness. If you have, the more serious a mental illness problem is, the more drug use will be used. And so there's kind of two rules there when you start taking a look at your patients and assessing them. Forgive me, I will say patient all the time. It's the way I grew up, but you're going to use client. Feel comfortable with that. Let's call that a cultural integration, okay? Culture is bigger than tradition and Indian versus non-Indian. It's our professions are cultural, and we need to kind of think about how we cross over all of those lines, because those lines make everybody mad at each other. We need to stop that. I wanted to share a little bit, I guess, on And again, this is a slide for you to take home. By the way, I have another use for my slideshow for you. It's to write your future grant. You can take data out of this, they're referenced, and you can use this material as you try to write about the importance and the future development of new grants. I'm going to go ahead and talk about risk factors for comorbidity. You know, if you have an early occurrence of either a substance use or a mental health problem, it will predict comorbidity. There's more happening earlier in life if you have one or the other. There are genetic factors that have been shown. Family history of concurrent disorders means offspring can have that problem too. There are psychosocial experiences. I bet, you think about your reservation and hear these statements. Unemployment, what if that's a problem for you? Poverty, unstable income, lack of social network, stress related to work or school, past or ongoing abuse or trauma, historical trauma. Females with higher rates of physical, emotional, and sexual abuse. That apply to anybody here? It really is remarkable how vulnerable we are. And we'll talk a little bit about social determinants in a while. But the prevalence, and I'm talking nationally now, there's 7 to 10 million Americans affected. Antisocial personality, bipolar, and schizophrenia are most likely to coexist with substance use disorder. And there's a high prevalence of trauma, and by the way, from a medical point of view, more likely to have cardiovascular disease, cirrhosis, or cancer. So there's medical comorbidity too. You don't want to forget about that side of the fence. So you might have to be talking to the medical side in your community as well. Okay, in youth, when we talk about prevalence, among youth who have addictions, substance abuse treatment, 62% of the males and 83% of the females are vulnerable to mental health problems. So high incidence, once again, almost 90% of those with a lifetime co-occurring disorder had at least one mental disorder prior to their addictions. So something's going on in the family. What's that telling you? How many people are doing prevention intervention in your projects? A good number. Thank you. I think that all of you need to take a serious look at prevention intervention. Why? Because it gets you into the schools, it gets you into the family, and you can start eroding that negative stereotype about what these problems are. There's a lot of reasons to want to do prevention intervention. It will get you in, the parents will understand what you're trying to do. Okay, comorbidity will increase treatment seeking. Very expensive patients. They cost a lot of money, and that's why ERs don't like them. The use of services will be increased. Social services, unemployment, vocational assistance, housing, all increased because of this problem. There's likelihood of no services because these people won't get help until it's too late. Treatment costs go up, poor outcome, and suicide risk. That must be for me. I heard that. The interesting thing that I want to caution you about, remember I told you now, you're working with the highest risk, toughest group of people to work with. Almost by definition, you need to be assessing suicide risk. That's very, very important for you to want to know what the risk is. I can tell you, you set up your program and you don't do that, and somebody commits suicide, if you forgive my phrase, well, I'll say it differently. What the heck is going on in your program? They're going to want to know why you let that happen, as if somehow you had control. So you want to assess suicide risk within your community. Well, let's talk about specific comorbidities very quickly. Once again, I'm going to go through these real quickly. Again, if you want to know more, you can Google or you can give me a call. But we're going to talk first about affective disorders. Affective disorders means what? Depression and manic depression. Both high rates, about, well, let's see what we have. 56%, about half of people with bipolar disorder, mood swings, manic depression, also have substance use disorder. 20% of youth with depression have a history of substance abuse. If you're working with school kids, you need to sort that out. Now this is an interesting one, you'll love the data. 15% to 75% of patients with substance abuse treatment have depression. I don't know about you, I've worked for years. I ran a program for 25 years for alcohol, drug problems, and mental health problems. And when I worked with those patients, nearly all of them had something going on with depression and anxiety. Loss of control, failure, all of those things. I think Chris Christopherson said, when failure knocks at the wrong side of the door. Schizophrenia, you might not see that very often, but every once in a while you're going to see a patient in your community. Very high, 47% have substance use problems. Now alcohol is used sometimes with schizophrenics to reduce the negative signs. Schizophrenic people have a very bad feeling about themselves and their lives. They withdraw, they have anhedonia, they don't like to talk to people. And alcohol especially is something that they can use, other drugs, to help them get out of that very bad feeling of discomfort. It also can decrease positive symptoms of hallucinations and paranoia. And one that if you're working with kids, you want to know about disruptive disorders. What are we talking about? Attention deficit hyperactivity and conduct disorder. These kids that are having problems in school and acting out behavior and not able to concentrate for the attention deficit are real difficult folks to kind of work with and high risk for drug problems. And so you want to know about that as you go through. Now, that's my general information about comorbidity. Now we're going to talk about amongst American Indians. And to talk about that, I'm just going to remind you, we have lots of difficulties. We have high risk for alcohol, tuberculosis, diabetes, accidents, poverty. You know those data. The thing you want to say, though, is a little bit like what the Surgeon General reported a few years back, and that is that American Indian people have the same disorders as the general population, but a greater prevalence of the problems, greater severity, much less access to treatment and care, and the cultural relevance is much, much more challenging in that environment. And the social context is disintegrated. What does that mean? Social context is disintegrated. It means that Indian people have many different dimensions. And some people are very, very traditional. Some people are not so traditional. Some people don't even like to call themselves Indian. And when we work with our people, we need to focus on identity and who the people are that are coming into your care. And you need to somehow figure out a way to work through that process in your various groups. I'm quickly going to talk a little bit more about mortality rates. I did a study of this a few years back, and I looked at all causes of death for Indian people and the alcohol, diabetes, and these various causes. The only thing I want to tell you is I did a study more recently of this with Dr. McCabe, and I found out that, anybody remember the plan for 2020, when we came out in the millennium year, and we're going to have a 20-year plan for looking at healthcare in Indian country. Well, I saw some things yesterday, last week, that concerned me. Our mortality rates are going up, not down. Now, is that because the problems are more severe and more difficulties are there, which is highly possible, or is it that we're collecting better data and we know more about what's going on? I don't know the answer to that, but the rates look like they're going up. That's a challenge for you in this process. Okay, trends among American Indian youth. American Indian youth are more likely to use tobacco, inhalants, alcohol, marijuana. They tend to initiate this at a younger age. They have higher rates of polysubstance, multiple drugs of abuse. I want to say there's no gateway drug for American Indian. Now, I might be wrong, I generalized. But Indian kids use what's available. If it's available, they're going to use it. It might be alcohol, but it might be drugs. Remember, heroin's getting down to the cost of alcohol. And that's a big concern for us. Certainly cigarettes, marijuana, sometimes they used to call those gateway drugs, but I think that Indian kids use what's available, and we need to be very aware of that. Okay, alcohol and other drug use may cause or mimic psychiatric symptoms. It really is important to kind of have mental health input into the care that you're giving these opiate patients. It's not a housing program. You know, it's an assessment, management, future development, and care program. We're going to talk quickly about best practices, and I guess I have a couple of things. Comorbidity is an expectation, not an exception. You must expect it to happen because it's going to be there, and you need to know that. And also I want you to remember that comorbidity is a chronic health problem. It's not short term. There's no quick fix. Everybody needs to know that. You mentioned that point very valuably this morning, that it's something over time that we need to deal with. Now, I have a whole list of things about why is treatment so difficult for alcohol and drug and mental health. Well, I just made a whole list of problems. And it's because health problems are there, family problems, isolation, financial problems, school problems, accidents, all of these things are there. And it's very difficult. And both alcohol and drug have these problems and mental health. And so it's a problem. It's going to be very, very difficult to unravel. And so if you look at best practice, and I'm going to give you my philosophy, and I've worked with evidence-based practice for years. I worked with guidelines for treatment when it first came out back in the 80s. And so these issues are important. World Health Organization, I think, does the best job of helping people, especially indigenous people worldwide, to look at what best wise practices are all about. And if you take a look at that, WHO says that a technique or methodology that through experience and research has proven reliability to meet the desired result. When they talked about indigenous earlier, they said that best practices are examples and cases that illustrate the use of community knowledge and science in developing cost-effective, sustainable survival strategies to overcome chronic illness. Now, I don't know about you. I listen to NIDA, I listen to SAMHSA, but I think that sometimes international studies that look at indigenous people have a deeper understanding of evidence-based practice. And I am encouraging all of you to take that look and establish for you what is a best wise practice for your community. Some of you will say, absolutely traditional. We want to be there. That's where our people are, and it works well for us. The canoe journey, anybody know the canoe journey? Canoe journey focuses on that. They teach language, they teach the history of the community, and they put kids into canoes to move their knowledge of what it is to be a member of their tribe. Other people, though, are going to look and say, you know, our tribe is small and we've lost our language. We're trying to do these things, but we're still our tribe. Here's the ideas we have that we believe in and that we think work. And that's where you understand and draw upon your use of a best wise practice. Another model that I'm going to quickly go through models. I don't know my time here, but I'm going to quickly mention the models of care. One group likes to look at the AMSA, the American Medical Society, looks at the issues of severity. And if you say on one line going straight up and down, that's the severity of the problem of addiction. The other line is the severity of the mental illness. And they divide up 4 boxes. And in the lower left box is the less severe mental and the less severe addiction. If you go all the way up, you have the less severe mental and the more severe substance. And over here, the more severe mental and the more severe substance. Which box are your patients in? That will help you establish a treatment plan for working with these patients. And you can design those yourself. You can personalize it to fit the boxes. There are ways that you can do that. Again, if you want to Google this map, you can find out the way it's done by AMSA, which is one way. And that'll help you get through a management program for these patients. There are other ways, treatment models. One is sequential treatment. Find one provider and then the other. So you treat the addictions and then you treat the mental health. You can also do them at the same time, separately. So you double up the patient's work. You got to do this and you got to do this. Got to do them at the same time. The other model that SAMHSA is promoting is integrated treatment. Both services provided by the same clinician or group. That's what's going on in Eastern Band, Cherokee. Integrated treatment by SAMHSA, you know a lot about that, the collaboration across disciplines. You've got to get people to talk to each other, and they're full-time people, once again. They're going to have to give up some time to talk to you. And so trying to look at integrated care means changing how you do your work. And that's the problem that Eastern Band Cherokee is dealing with now, about how do you share that process and change the way you do your work. If you will, you might use a model for how to do integrated care. And this is a graph that looks at all of the things that you want to be in, the strengths and responsibility, respect, hope, person-driven, peer support, all of these values about what happens in integrated care. You might be able to develop an integrative care model based upon those kinds of thinking. My favorite model is very idealistic, and I'll start it this way. If you had everything in the world to treat this patient, what would it look like? Well, it would look like this. You'd have all of these services: assessment, behavioral therapy, pharmacotherapy, substance abuse management, all of those in the center, but everybody working together around the patient. Now, if you're going to write a grant again, this is a good model. It's a very good way to take a look, but you got to live up to it. That's the other problem with charts. I will tell you that getting mental health and medical services to work together is very, very important. And I would just want to highlight that quickly. My love of the last 15 years has been to talk with tribal groups about social determinants of health. And This started with a guy named Michael Marmot in London called the Whitehall Studies. And he did a study. He looked at in England, they have classes. You guys, what's that program, Downton Abbey or whatever it is? They talk about, below in the basement people and people upstairs, downstairs, that kind of thing. England is known for class system. And he decided he'd want to study that and see what the differences was. And he had a very interesting question. How come there's higher morbidity and mortality in the lower class? Why is that happening in England? And so he did a study of that, and he found out that higher status folks, his words, live longer and they're healthier than the lower status folks. And he got to thinking about that, and he worked with the World Health Organization again, and he decided to study this and pursue it with indigenous peoples around the world. And if you Google social determinants of health, you'll find his studies in the World Health Organization about how to work with indigenous peoples and what he found and what he thought was important. In a few words, though, higher status folks live longer and they're healthier. So what does healthcare improvement need? It needs more than money. It really needs more than the money that you all have received. If that's all you're doing, you're a real good keep an Indian employed project. But you're not going to be able to do the work until you look at the larger issues. And what social determinants has said is that you have to give your patients opportunity to change their lives. You have to empower them. Empowerment is not an easy word in Indian country. We don't feel very empowered. We don't get that information from our current president. Last time I'll mention that. We need to have security. Like I better not be dragged out of this meeting because of what I just said. We need to have control, and we need to have dignity. Your program needs dignity for the people that are there. And if we look at that from an Indian point of view, with an American Indian family in the middle, we need to look at the individual lifestyle factors, the social community network, and ultimately the general economic and cultural environment around that individual. I think this, when I present this to tribal councils, they actually get it. They realize that MAT's not going to cure the patients that are having problems. It's a good advantage, but unless you're dealing with the whole environment within the community, that person's not going to get better. And that's something I just want to share with you about comorbidity and how that works. Okay, now I'm going to move over and tell you about how many people do risk and protective factor assessment. If you work in school systems and communities, it's a very good way to set up a program. When you interview a patient, you ask yourself, okay, what are the good things going on in this poor guy's life? What are the strengths? And the strengths are the protective factors. Do they have strong family bonds? Do they have parental monitoring, parental involvement, success in school performance? Pro-social institutions like in the family, are they engaged in working with the community? And then conventional norms about drug abuse. If you're lucky, you'll find a few of those. But always when you assess a patient, look for strength. And then turn around and look at weakness. And the risk factors are obvious. Ineffective parenting, chaotic home environment, lack of mutual attachments, I could go on. Poor social coping skills. All of these things are important for you to look at the risk factors this person is undergoing. Now, I made a list of what good integrated treatment approaches can work. And I just made a list, and staged interventions. Anybody know what that is? Anybody here know that? Staged interventions, when a bunch of school teachers get together with the parents and develop an overall outline and plan for that child to get through the problem that they have. And they work and try to find ways to tinker with that individual's life to make it work better. Another one is assertive outreach. That's a home visit. You go there and talk about what the problems are and work with the family. You might see a lot of chaos in the family. You might see an unmotivated family. You might see an unengaged family. And you have to kind of know what to do with those problems and seek some kind of support to get through it. So long-term perspectives and comprehensive and cultural sensitivity approaches all count. I made a list of those things. You just have to Google them to kind of understand what those might mean in your program. Okay. In youth programs, family therapy is very, very good to do, bringing the people together to work through the problem. Some of you counselors, how many people do family therapy? Anybody? Very useful if you're going to have a kid program. Frankly, it's very good for adults too. Bring the kids in. You'll really help establish what should not be done if you bring the kids in. Multisystemic therapy. Big buzzword, but what it means is all the systems working together. Social workers, vocational assistants, other people trying to solve problems for that person. We heard a little bit in Joel's comment about how he works. He brings that together in their halfway house as a part of their aftercare and program. I made another list, and it's just a list of things you can do to intervene with adults. Cognitive behavioral therapy, I'm going to mention two. Cognitive behavioral therapy and motivational enhancement therapy. Those are two programs that have been now trained and validated in Indian country to be used. They work. Indians are good at motivational therapy and cognitive behavioral therapy. I did some of the very first training working with Native people about both of those. We trained 80 counselors in the Northwest to use motivational enhancement therapy. We did that for a year, and then we asked them to help us write a new book on a manual for motivational enhancement therapy. That's available online. We Indianized it. If you forgive the word, I don't mean it badly, but we made it Indian. And you can make it yours. If you look at the Indian version, you can change and make it your tribe's version. There's nothing magic about it. Just own it and make it your way of doing it. I can guarantee you, the hardest thing for Native people to take on a project like motivational enhancement or cognitive behavior, how many people here are trained in AA treatment? Very few. I'm impressed. AA treatment is very different because it's advice giving. You tell people, that's not the way I did it. You need to do it this way. And motivational enhancement therapy works in the opposite direction, asking the patient to bring forward their ideas. You don't give advice, you listen and you help them develop ideas. Once they kind of get that point, they take off. It's the best group of training people I've ever worked with. And I'm sold on, we can own motivational enhancement therapy in Indian country. We can own cognitive behavioral therapy. They're ours. You're going to hear somebody tomorrow say, study it and make it better, make it yours. I think I want to just mention barriers to treatment. You've heard a lot about it. By the way, I don't know if you know this, but last month we had the worm moon, and that's the moon over Mount Hood in my part of the world. There's a disconnect between systems. Professionals are undertrained, and there are too many ownership territorial problems. Patients are underdiagnosed and they're undertreated. Neither integrates well with the medical and social services. So those are the problems that we see. And we need to look at another thing. All of your mental health programs are funded by little fund control points that float in from Washington, D.C. How many of those people who fund your fund control points have been to visit you? How many people know what your reservation looks like or how big it is? How many people understand the access problem of going hundreds of miles to seek care and lining up? You know, I visited one reservation, and that group's here in this room, that had a 4-month waiting list for suicide ideation in kids. You like that idea? You know, you want to bring risk to your community, you know, you need to provide access. But they couldn't, because they only had 2 people to do the work. And that's just not a good way to do it. And so our funding from the government is narrow-minded, not integrated. They have demands on you to produce things that don't make sense. I'm a big person in believing that we need to integrate the funding and bring it to the tribe and help the organizational system use that money in a way to direct the problems that really need care. I think that would be a better way to do it. Okay, promising strategies. Very quickly, you know, the World Health Organization, UNESCO, says scientific and indigenous knowledge should be integrated in interdisciplinary projects dealing with culture, environment, and chronic illness. And so, you know, do you get to do that? Does our government think that's a good idea? You know, we don't get that kind of information. What we get is something called best practices that science and the community standard of care gives us. And that's called best practice. I like to call it best wise practice if you look at cultural values. You need to involve the philosophy of the community, belief about causes. What does the community believe causes the problem? What's their theory about why this happens? And what would they do to treat it? Is the local innovation and trial and error approach. You know, we have indigenous knowledge. We've treated people with herbs. We've treated people with all kinds of care that gets left behind whenever we don't integrate that into our system and understand it and appreciate it as a Western medicine person. So a direct application of Western medicine? No. Integrate the system? Yes. And we need to be the student in Western medicine. Okay. Another model. Look at the individual, the family, the peer, the community, and society. Racism is here, and it's real. It's a part of the difficulties that we have to deal with. And again, if you want to look at integration of care, you go with the schools, the churches, the recreation therapy, housing, justice, tribal council, administration, health resources, and public safety. All of those groups need to work together in developing your healthcare system. I mentioned some resources in the slide, and you can Google these again from SAMHSA, the NIAAA, drug abuse, NIMH. All of these people have websites where you can gather information for knowledge and education and for your next grant. Okay? I don't think that we're an end to this. Now, I put my phone number in, and I've got my website. If you go to oneskycenter.org, all of our information can be downloaded. The monograph on motivational enhancement therapy is there. It's a monograph on suicide prevention that's there. And you're welcome to use those, and you're welcome to be a part of it. I want to thank you all very much for having the honor. I honor you in this process because you all are the ones that are going to make a difference. Thank you.
Thank you very much, Dr. Walker. I think that's Eugene. I recognize that guy. It's 2:36, so what we'll do is let's take a 15-minute break, and then we'll come back to the second presentation before we move into the panel.